Hello, everyone, and welcome to this exciting session on complex PCI at TCT Asia Pacific. We have a number of exciting presentations coming up, and we'll just jump right into this because we've got an action-packed session. The format of this was going to be 6 minutes of presentation followed by 4 minutes of discussion.
Welcome to TCTAP 2022 case session 5, the complex PCI. Good morning to co-moderator, panelist, and the case presenter of this session. And now I request Dr. Khairul Shafiq Ibrahim, University Technology, Mara, Malaysia, and topics is left main instant restenosis, a successful story of using shockwave technology. Dr. Khairul Shafiq Ibrahim, go ahead.
Good morning and thank you to Mr. Moderator. So my topic today is on left main instant restenosis, successful story of using shockwave technology. My name is Khairul Shafiq Ibrahim from University Technology, Mara, Malaysia. There's no conflict of interest. So let's go straight to the case. So I've got Mr. AM, a 63-year-old man with comorbids of ischemic heart disease, in which the left main to LAD was stented back in 2014 with DES 3.5 × 20. He also known to have type 2 diabetes, hypertension, end-stage renal disease, and only started on regular hemodialysis 1 month prior to this admission. So he presented with typical textbook of acute onset chest pain, centrally located, pressing in nature, associated with shortness of breath and diaphoresis. On examination, the blood pressure was 168/88, heart rate of 98, and saturation of 98% under room air. On auscultation, the heart sound was normal with minimal biphasic crepitations. So ECG showed diffuse ST depression with ST elevation at the AVR. Blood test showed normocytic normochromic anemia with hemoglobin of 8 and high sensitive troponin T of more than 6,000. Echocardiography showed left ventricular ejection fraction of 53% and hypokinetic areas at the LAD territory. So this was the catheterization findings. You can see there's critical stenosis ISR at distal left main and proximal LAD. There's also diffuse disease at the circumflex. And there's also lesion from distal end of the stent, old stent, extending to the mid LAD. On the right system, there's no significant stenosis seen apart from ostial marginal branch. And we can also see there's collateral to the LAD. So the case was discussed with the patient whether they want to go through bypass or PCI. And the patient decided for PCI. So this was our interventional management. So we used right radial approach, and 6-in-7 French slender sheath was used. EBU 3.57 French guiding, run through wire to circumflex. It was kindly easy to pass through the circumflex because the wire kind of deflected by the calcium in the osteo LAD. However, wiring the LAD was technically difficult, so we have to use different view and a couple of times need to adjust the shape of the wire. So in the end, we managed to wire the LED using Xeon blue wire. So we start off by preparing the lesion with NC 2.0 to predilate the lesion so that we can allow smooth delivering of OCT catheter. So this was the first OCT run. We can see there's calcium-mediated left main to LAD instant stenosis. There's also moderate to severe stenosis distal to stent edge. The old stent was nicely opposed and there's no evidence of underexpansion. The distal left main MLA was 4.4, whereas this proximal LAD MLA was 3.1. So the lesion was prepared using IVL 3.5 × 12. The picture on the left, you can see there's kind of dog bone shape, and after 8 runs of IVL, it's kind of clear off. So to confirm our findings, we do a second run of OCT. And can compare the pre-IVL and post-IVL picture, the calcium channel has been cracked. So the lesion was further prepared using NC 4.0, and the lesion from distal edge of stent to mid LAD was prepared using NC 2.0. So we first stent the proximal to mid LAD lesion with 2.75 times 33 stent and further optimize it using NC 3.5. And the in-stent restenosis, we use DEB 3.5 times 20. So this was the final shot. You can see T3 flow down to distal LAD. I managed to preserve the circumflex. So the MLA was 7.75 for distal left main, and MLA for proximal LAD was 6.79. So this is the final OCT run, which showed no edge dissection, good stand-up position, and we are happy with the results. So in conclusion and take-home message, shockwave intravenous lithotripsy application in treating calcium-mediated left main stem, proximal LAD in-stent restenosis is feasible and safe. IVL has the potential to yield promising short and mid-term results in treating calcified ISR. Of course, intracoronary imaging is important in optimization of coronary intervention.
Thank you, Dr. Khairul Shofik Ibrahim, for your elegant cases. Now, session is open for question and
Mr. Chairman, can I make some quick comments to the case, if I can? Yeah, thanks, Khairul. I really enjoyed your case, very nicely presented and good end results. So I think this is a typical case we see every day, so I really enjoyed the case. ACS, high bleeding risk, end-stage renal failure with in-stent restenosis, surprisingly after 8 years from the index procedure. Firstly, I was surprised you went through the radio route for someone with end-stage renal failure. Secondly, I felt that could have considered a higher, larger NC balloon or some form of scoring balloon before the IVL because it's after all costly. On the OCT, I couldn't quite appreciate that it was fully circumferential in nature, but when appropriate, I think IVL in the left main is actually very safe and much better than trying to roto through a previous stent site. In this case, I thought could have gotten away with good lesion prep with a larger NC or scoring balloon. I thought the end case where you just did a DEB was a very, very good approach for high bleeding risk case. In this case, I might have kissed out the osteocirca, but I think it was a good result at the end. Thank you very much for the case.
Yeah, Khairul, just one point here. I think you demonstrated what a lot of people would wanted to know is whether IVL is safe in intervening the distal left main or the left main into the LAD. And I think you have showed that it is safe. And I think that's a learning curve that we need to overcome here. And I think your approach for imaging prior to that just further adds the fact that, imaging is important to identify what kind of calcium you have, how deep superficial calcium is. And of course, your end results are fantastic. So congratulations. Thank you.
Thank you. As time is constant, I request next case presenter, Dr. Wei Lin Chen, Division of Cardiology, Department of Internal Medicine, and National Taiwan University Hospital, and NET Taiwan. The case title is Case Report, Refractory Chest Pain After Transcatheter Aortic Valve Implantation. Now I request Dr. Wei Lin Chen to present his case.
Okay, good morning, everyone. I'm Wei Lin Chen from National Taiwan University Hospital. I would like to present an interesting case with refractory chest pain after transcatheter aortic valve implantation. There is no conflict of interest to disclose. This is an 85-year-old woman complained of intermittent chest tightness and dyspnea for 6 months. She has a history of hypertension, diabetes mellitus, paroxysmal atrial fibrillation, and end-stage renal disease under regular hemodialysis. On physical examination, I heard high pitch, crescendo, decrescendo, and mid-systolic murmur. The initial impression was a aortic stenosis. Thus, we arranged a echocardiography for the further evaluation. The echocardiography showed normal ejection fraction with 72%. We found a concentric LVH without pressure gradient. And also, calcified aortic valve with severe stenosis was also noted. Despite there was a concentric LVH, there was no significant outlet obstruction or intravascular pressure gradient. We then arrange a computer tomography for the further evaluation. A calcified lesion at the proximal LAD was noted, and severe aortic stenosis was also noted as we noted on the echocardiography. Before the TAVI, we performed a coronary angiography to check the vessel. There were stenotic lesions at osteo and middle LAD and at the distal, and distal circumflex artery. Okay, but the flow was still adequate. Thus, an LR 26 millimeter self-expandable valve was implanted smoothly. There was only mild aortic regurgitation after the procedure. Although we treated the aortic stenosis, the patient still complained of intermittent chest tightness. She came to our emergency department 7 months after the procedure. The laboratory test showed elevated troponin T, and the ECG showed left LVH pattern with higher ST segment at V1 and AVR. Diffuse ST depression and new onset T-wave inversion was noted. The impression was the stenotic lesion at the proximal LAD. Also, we arranged the coronary angiography again. The coronary angiography showed an osteo and middle LAD lesion, but there was no significant deterioration compared to the last study. The lesion at the distal circumflex was also same to last study. Those IVAS was done to check the vessel morphology, and there was a stenoculation and eccentric plaque with calcification at the distal ligament to proximal LAD and middle LAD. Under the IVAS guide, and DES was deployed to the from the distal left main to proximal LAD. After the procedure, the flow was adequate and there was no significant stenosis on the coronary angiography. Although we treated the severe AS and CAD, the patient still complained of intermittent chest tightness. The follow-up echocardiography showed still normal ejection fraction, but left ventricular outflow tract obstruction with pressure gradient of 63 millimeter of mercury was newly found. To treat the HOCM, we prescribed bisoprolol and diltiazem initially, but the patient still have the chest pain and chest tightness. Thus, we implanted permanent pacemaker for dual chamber pacing. The symptoms relieved after the treatment, and the follow-up echocardiography should significantly decrease pressure gradient from 63 to 9 millimeter of mercury. In summary, this patient had a refractory angina and due to severe aortic stenosis, coronary artery disease, and hypertrophic obstructive cardiomyopathy. We treated the severe AS with the TAVI and treat CAD with PCI and treat HOCM with beta blocker, calcium channel blocker, and dual chamber pacing. All symptoms relieved after the treatment. In conclusion, elderly patients with severe aortic stenosis often have coronary artery disease and hypertrophic cardiomyopathy. TAVI can only treat the valvular stenosis, but may worsen the left ventricular outflow obstruction, and also it may make it difficult to perform coronary angiography after TAVI. So we suggest that this patient require more dedicated evaluation prior to the intervention. Thank you very much for the attention.
Thank you, Dr. Wei-Lin Chen, for your nice cases. Now, I request panelists for questions and comments regarding this case.
Hi, Dr. Rashid here. Thank you. This is an interesting case that you presented. Initially, when you performed the angiogram, I thought there was at least a moderate distal left main disease on that imaging, especially on the cranial view. I'm actually interested in the IVUS data that you had post TAVI. What was the minimum luminal area of the distal left main?
The minimum lumen area at the distal left main and proximal AD was around 3 square meter.
3 square meters, okay. And the rationale of putting in a core valve in this lady was, I assume, a smaller annulus. Was that the reason why a core valve was decided?
So, we think it's calcified in relative small valve. The patient was very thin and the body size was small. Yeah.
Okay. All right. Okay.
Okay. Thank you, Dr. Wei-Lin Chen. Now I go to the next presentation, and next speaker is Tomoki Uchiai Shonen. This is from the Kamakura General Hospital, Japan. His title is Successful Transcatheter Aortic Valve Replacement with Chapin 3 valve in a patient with quadricuspid aortic stenosis. Now I request Dr. Tomoki Uchiai Shonen for your case.
Thank you, Chairman, and good morning, everyone. Today, I'd like to present a case entitled Successful Transcatheter Aortic Valve Replacement with Sapien 3 valve in a patient with quadricuspid aortic stenosis. I have nothing to disclose. The patient is a 75-year-old woman presented with progressive shortness of breath, and her past medical history included coronary artery disease, and diabetes, and dyslipidemia, and chronic obstructive pulmonary disease. And she was found to have severe aortic stenosis and referred to our institution for transcatheter aortic valve replacement. And pre-procedure transthoracic echo showed a severe aortic stenosis with a mean gradient of 48 millimeter mercury and calculated valve area of 0.74 square centimeter. Her left ventricular ejection fraction was preserved. And as you can see, a CT scan showed quadricuspid aortic valve with a mild calcification in the aortic valve complex. And the annular area was 63.5 square millimeter, and perimeter was 68.3. And her sinus of Valsalva is around 29 millimeter. And the patient had a relatively short membranous septum of 2.3 millimeter. and there was no significant stenosis in iliofemoral arteries. So the valve size was determined by the annular area, and 23 mm Sapiens 3 valve was used. And the procedure was performed under conscious sedation via transfemoral approach. And during valve deployment, it was very challenging to identify optimal fluoroscopic perpendicular view projection, showing all 4 cusps in line. As you can see, there are 4 cusps. And if we look at this yellow and green and red cusps, perpendicular plane has to be like this. But when we look at this orange and green and red cusps, the perpendicular projection has to be like this. So if we select white line for valve implantation, it might increase the risk of valve pop out because of high implantation. So finally, we selected this blue line for valve implantation. And the patient had a successful implantation of 23 mm Sapiens 3 valve. And angiogram showed no paravalvular regurgitation. And post-TAVR transthoracic echo showed well-functioning bioprosthetic aortic valve with no paravalvular regurgitation. And she didn't have any new conduction disturbances after TAVR. So this case demonstrates that the quadricuspid aortic valve stenosis can be treated using TAVR with favorable clinical outcomes. So during TAVR for quadricuspid aortic valve stenosis, identifying an optimal fluoroscopic perpendicular valve projection showing all 4 cusps in line is often challenging. So in such cases, using a 3-cusp perpendicular view may be a good alternative in terms of successful valve implantation. Thank you for your attention.
Thank you, Dr. Tomoki Uchiai Shonen, for your nice case. Now, open for the questions and or comments regarding this case.
Hi, I was wondering whether you could identify this angle on CT rather than on fluoroscopy.
Thank you. Actually, we obtained perpendicular fluoroscopic projection from CT scan, but as you know, it often happens that perpendicular view from CT scan is different from the view from angiogram, and this case was like that. And actually, it was very challenging to identify optimal fluoroscopic projection because it was different from the one from CT scan.
I think if you use another platform of valve, just the Evolute valve, it can give the room for the valve for the deploy in the high space for the cast on the ILV size like this.
So yeah, in this case, there was no significant calcium in the aortic valve, so we selected Sapiens 3 valve. But if there is a severe calcification in the aortic valve, we would choose Evolute valve.
Well, I think we should move on to our next session, which is myocardial infarction in patients with cardiogenic shock.
Good morning, everyone. I'm Jonathan from Hong Kong. It's my pleasure to speak to you today on contemporary management of STEMI with cardiogenic shock. I have no disclosures to make. So to begin with, we have a 66-year-old gentleman with a history of smoking and otherwise unremarkable past health. He presented with acute chest pain while jogging, and on arrival at the ED, he had a blood pressure of 95/60 with cool, clammy peripheries. And this is his first EKG at the ED. You can show it's a left main pattern with ST elevation at the AVR and then diffuse ST depression. And he was immediately transferred to the cath lab. At the cath lab, his blood pressure was still borderline with cool peripheries. We did a bedside echo, his ejection fraction was 40%. And we quickly obtained a 7 French right radial axis and a 3 French right femoral axis. The right femoral axis was obtained in case we needed mechanical support. Then we measured the LVEDP, which was around 30, grossly elevated. And then we took an angiogram of the right side. Fortunately, it was unremarkable. And then on the left side, well, unsurprisingly, you can see the left circumflex was occluded. There is a very tight lesion in the proximal LAD. So now we are facing with an occluded left circumflex and a very tight proximal LAD in a patient with borderline blood pressure and a decompensated state. So we decided to put an impeller first because of the borderline blood pressure, the grossly elevated LVEDP, and the complicated coronary anatomy. And remember, we got the right femoral axis up front, so we fairly dilated the 3 French axis into 14 French and put in impeller CP with Smart Assist. And here's the impeller going up. And then we quickly wired the left circumflex first. The workhorse wire went in pretty smoothly. And then we used a small semi-compliant balloon to daughter the lesion. We did not actually inflate it. We just daughter it at the site of the occlusion. And then the flow came back. And you can see there's a very focal thrombus at the proximal third causing the occlusion. And then we decided to just directly stent it. And we put in a 3-5-15 stent in the proximal left circumflex. And this is what happened afterwards. Unfortunately, there's distal migration of the thrombus into the mid-cert into the OM branch. Although the distal flow was still maintained, the blood pressure was still fine. And then we decided to inject some glycoprotein 2B3A through a microcatheter inside the left circumflex, hoping that we could dissolve the clots there. And you notice now that the blood pressure, despite the impeller support, has gone down a little bit, but it's still hanging in there. And this is our dual lumen catheter for the injection of the glycoprotein 2B3A. Here we use integrinin. And because we know glycoprotein 2B3A inhibitor needs time to act, so we decided to move on to the LAD while we're waiting for the glycoprotein 2B3 to work. And then we quickly wired the LAD. It was not easy. We needed a microcatheter support. And then we ballooned it. We stented it with a 3024 stent. And of course, we did the PCI under IVUS guide. And the stent blending was fine. Did a little polishing with stent high pressure. So we put stent high pressure with 3.5 NC and 4.0 NC according to IVUS. And this is the angiogram of the LAD after stenting. And unfortunately, after giving the minutes, the clot was still there despite the integralin. And so we needed to do something more. And we decided to do mechanical thrombectomy using the penumbra system. And here's the penumbra system going in. And then this is the penumbra catheter. We only did one run. You see here we started aspiration. And then once the blood flow stopped over the catheter, we retrieved the catheter out slowly. We maintain the suction on at the system to make sure that the clots do not migrate distally or embolize into the LAD. And then we also clear off the system by aspirating the guiding catheter and the pressure system. And this is what it looks like after the mechanical thrombectomy. You can see with just one run of penumbra, the clots were all cleared from the left circumflex. And then we double check the landing and the stand at position expansion with IVUS. The landing was actually fine. There wasn't any disease distal to the stand. And but the stand was definitely underexpanded malapose. So we further optimized it with a 4.0 NC. And this is the angiogram after the stand optimization. So there are several discussion points here, but with the limitation of time, I cannot go through every single one of them. But first of all, I think we initiated Impella support in this case early. Based on the clinical presentation of the patient, the hemodynamic status with grossly elevated LVEDP and a very borderline systolic blood pressure and a poor LV systolic function. And also the coronary anatomy, there's the occluded left circumflex and a very critical proximal LAD. However fast we are, still takes time to recanalize both of them. So we decided that Impella early upfront is necessary. And also we use a catheter-based pharmacological and mechanical thrombectomy to clear off the left circumflex clots. I think we could argue that maybe if we used the mechanical thrombectomy upfront, we could have solved the issue more quickly. But it's really hard to predict. And many times the globin 2B3 would work the magic. And also there's a third discussion point on whether we should completely revascularize this patient or not, especially with the emergence of the new guidelines from the American College of Cardiology. If the patient is having cardiogenic shock, should we really recanalize the non-culprit vessel, that is the LAD in here? But I would argue that since we already have the Impella inside, it's probably better if we just revascularize the LAD as well, so to improve the chance of weaning the Impella at the end of the case, which we did. And also, so we do not have to bring the Impella back into the CCU, which creates a lot of complications. So I'd love to hear your thoughts about this case. Thank you very much.
Thank you so much for this excellent case. This case is now up for discussion. I think, as you mentioned, the key learning points here are that the culprit shock trial, which showed that we should be going for a culprit-only strategy, had mechanical circulatory support use in only a very minority of cases. And once you've actually gone ahead and used MCS, in those situations, the renal injury and the contrast-related injury may be less, and therefore we should think about that.
Yeah, I totally agree. I think if we have mechanical support in use, that's a completely different ballgame here. And the culprit shock trial would probably not be applicable in this patient.
Jonathan, nice case. How is the patient doing?
The patient actually did very well. Sorry, I forgot to mention. So at the end of the case, we wean off the impeller. So we did not need to bring the impeller into the CCU. The blood pressure actually was much better after we complete the revascularization. And the patient only needed a single inotropes at low dose when he leaves the cath lab. And his ejection fraction actually improved to 50% on discharge, and he was doing fine without any end organ damage.
Thank you.
Thank you.
What DAPT choose for this patient?
So we use aspirin and ticagrelor. So in our center, it's our protocol that the patient be loaded with ticagrelor when they came with STEMI and for primary PCI.
Excellent point. I think the other interesting point about this case is how imaging guidance was actually helped you with regards to optimizing the LAD and the circumflex stents. I mean, I was surprised it was you could able to go up to a 4, but I guess imaging doesn't lie. And I guess the other thing is the MCS really helped you to control the situation for you to be able to do imaging guidance in the setting of a STEMI. So excellent work.
Thank you very much. Yeah, exactly.
So I think on the,
for one last
sake
comment.
of time, we should probably move on to our last case, which is going to be an entrapment of a rotowire. So you broke it, you fix it. We're looking forward to this last presentation.
Good morning. I'm Thilawat Yupakanon from King Chulalongkorn Memorial Hospital. I would like to lead you to the case when you confront a rotowire entrapment and loss in the LAD. This is the case of 92 years old male who had intermittent cardiac chest pain on the exertion. He had a history visit at emergency room with the biventricular heart failure about 4 times in the last 6 months ago. His underlying disease include double vessel disease and the PCI at the proximal RCA about 4 years ago, hypertension and dyslipidemia. The physical examination showed that solid lumping murmur get through at the apex. The ECG showed the frequent PAC and pathologic Q wave in lead 3. The chest X-ray and lab result were shown here. The echocardiogram showed normal LV systolic function despite inferior and inferior septal wall were hypokinesia, but the systolic motion technique was preserved. So this patient had a chronic coronary syndrome, which made the high clinical likelihood of obstructive CAD. Then coronary angiogram was performed to confirm the diagnosis. The left coronary system showed chronic total occlusion at the mid-LAD. Then receive collateral circulation from the bridging artery of the proximal LAD. The left circumflex was normal. In the right coronary system, there was no instantaneous stenosis at proximal RCA, with the borderline significant stenosis at the mid-RCA. The physiologic study was performed. The result I show you. So the PCI at the mid-RCA was deferred. As the RCA lesion has been deferred, so the mid-LAD CTO was the most likely cause of the cardiac symptom in this patient. The correlate of the such CTO would help improve angina, exercise capacity, and quality of life for the patient. The predict procedural risk was high according to the progress CTO score. However, the success rate was also high according to the JCTO. So we decided to proceed the revascularization by the PCI after anatomical and surgical risk assessment with an indication of the symptom of limiting angina. The target lesion is the mid-LAD CTO. We plan to catheterize with the sixth flank with XB3 via live femoral artery, and we prefer to the anti-gate by escalation technique. Maybe needs the rotator atherectomy. Anti-gate Y escalation technique with the pilot 50 and the feeder XT was failed, but the lesion could be successfully passed by the conquest ball and the 5-course microcatheter. However, the tip of the 5-course microcatheter could only reach just proximal part of the CTO. Rotator atherectomy was done using the rotor-wide floppy and rotor-limber 1.25, and successful part deletion at the 4th attempt, as I show. There was you may see that there was the deformity at the distal guide wire. Then we tried to fix the such deformity. However, we lost the distal end of the guide wire into the distal AAD. When you fear the guide wire loss, you should consider the fragment remove depending on the location or accessibility. If you can't removable, you can consider using the micro snare or multi-wire twirling technique. While if unremovable but accessible, you can fix with additional stent. However, if not, conservative as preferred. For in this patient, I showed the multi-wire twirling techniques using the Pilot 50 and Samurai guide wire. Inserts in the same torque. Most of it was removed, but the small fragment of the distal end of the guide wire was remained in the distal AAD as I show. Then we proceed to the PCI with zero remote eluting stent at the proximal to mid AAD. This is the final angiogram. Pay attention at the location of the remaining of distal guide wire in the distal AAD. There was no flow limit or perforation. When you confront guide wire loss in coronary, one should realize that it can induce thrombosis. It can lead to the myocardial infarction. In conclusion, the aggressive manipulation of the guide wire combined with the active deformity or entrapment are the key factors that contribute to the guide wire loss in coronary. To prevent, make sure to handle guide wire gently and make sure to hand to the guide wire properly straight before you remove. Retrospectively for this case, I might stop the manipulation when I feel the resistance and also advance the microcatheter or small balloon more distally and pull it more gently in the order to improve the outcome when I confront a guide wire loss in coronary. Thank you, your attention.
Can I find out from you what are your thoughts about the mechanism of the wire fracture? I'm still not certain what's the cause for the fracture.
Okay, I suspected the distal guide wire deformity, distal guide wire of floater wire deformity, and maybe entrapment in small band in the distal LAD. And when I try to fix the deformity or the adjust the distal guide wire, can make the tension and make the distal guide wire loss in coronary.
When you snared out whatever was left, how long was that segment of?
About 5 centimeters of the guide wire is remain.
Dr. Thirawat, yeah. So guide wire fracture actually is not common, but it's actually very important because we used to see it in the older wires, the newer wires, not too often. But I think you have highlighted a very important case here because it serves to remind us that, you know, we have to be very careful when we handle our wires, especially whether it's our wiper wire for the orbital atherectomy or your rota wire, because you see the thing is these wires are different from standard workhorse guide wires, and we tend to be a bit forceful trying to get the wire all the way down, and you know sometimes it gets stuck in the calcium, or you know it's entangled or it's knuckled up, and you keep turning. So I think it's your take-home message of the point where, you know, we have to handle our guide wires carefully. I think it's very important, and that forms the basis of coronary intervention. Thank you.
Thank you.
Thank you, Dr. Thirawat. That's an excellent case. I was just wondering just about Dr. Tan's initial question about the mechanism. Was there a lot of twiddling to get the wire down to this LAD? Because I wonder whether, as was noted by Dr. Singh, whether there could be some knuckling involved in there. And as you keep going in and trying to reposition the wire, especially with a rotor wire where sometimes it can be pretty flimsy at the end, it could probably just rupture off, because I'm surprised that there is, as you said, 5 centimeters left in the vessel, which means that there is actually a lot of wire just entrapped on its own. Was there a lot of maneuvering when you tried to deliver the rotor wire?
Yeah.
Now, thank you, Dr. Thirawat Jiopakanan, for your nice case. Now I request Dr. Harsimran Singh from the India, and his case is cheap choice or only option for complicated post-COVID case with severely calcified left main trifurcation lesion, and from the Sri Ramachandra Institute of Higher Education and Research, India. Now I request Dr. Harshimran Singh to present your case.
I'm Dr. Harshimran Singh, and I'm a cardiology fellow at Sri Ramachandra Institute of Higher Education and Research, Chennai, India. The case which I'm going to discuss today is complex and high-risk coronary intervention, which is a choice or only option for a complicated post-COVID-19 case with a severely calcified left main trifurcation lesion. So this is the background of the patient. This 79-year-old patient who is a known diabetes and hypertensive was admitted with history of fever and cough in a desaturated state and was diagnosed with COVID-19. And patient was treated on the COVID-19 protocol. And on the 14th day of admission, patient suddenly he developed acute pulmonary edema and went into hypertension and was started on inotropic sport. Since the patient was under medicine department, we got a call and patient was diagnosed with evolved and T-Reval MI, and the ECG shows Q wave in V2 to V5 with ST elevation, and 2D echo shows severe LV dysfunction with grade 1 diastolic dysfunction and severe hypokinesia in the LAD territory. So patient was in a cardiogenic shock state and in acute pulmonary edema. So patient was intubated and was on mechanical ventilatory support. In view of cardiogenic shock, and patient was on double inotropic support. After discussing with the family, we decided to go for a coronary angiogram. And coronary angiogram shows densely calcified distal left main and has 50 to 60% stenosis. LAD territory, it has a long segment lesion from ostial to mid segment with maximum severity of 90-95%. Ramus intermedius has an ostial 90% lesion, and LCX, which is a dominant vessel, has 80 to 90% ostial lesion. RC is a non-dominant vessel with 70 to 80% osteoproximal lesion. So we discussed the coronary angiogram with the cardiothoracic team, and since the patient was declared unfit by anesthesia people, so after discussing with the family, we don't have any other choice to go for a complex high-risk PCI. So patient was put on IABP through left femoral artery, was cannulated with 7-French sheath, and IABP was placed through the right femoral artery. We kept the TPI if there is a need for a rotablation in the procedure, and with 7-French EBU, a left coronary artery was hooked. And first we crossed the run-through wire, and with us using fine cross micro catheter, run-through wire was exchanged with the Grand Slam wire for extra support. So we did a vessel preparation in the LAD. Pre-dilatation in the LAD was done using 1.5 into 10 mm Ryuri balloon followed by 2 into 10 mm Apollo balloon. Later, IVS was done, which shows severe calcification with more than 270-degree arch. So we decided to go for calcium modification by using IVL. So first, we did a pre-dilatation using 2.5 into 10 mm IQ force balloon followed by IVL in the LAD using 3 into 12 mm balloon. Shockwave balloon. So after preparing the LAD vessel, LCX was, we planned to prepare the LCX vessel. LCX was pre-dilated with 2 into 10 mm Ryuri balloon. IVL balloon, we tried to negotiate but could not cross the LCX. Then we used a super high pressure OPN balloon 3 into 10 mm size for pre-dilatation in the LCX and in the left main. after preparing the vessels, the mid LED was stented using 2.75 into 30 mm Resolute drug-eluting stent, and from left main to mid LED, we did stenting using 3.5 into 38 mm Resolute drug-eluting stent, overlapping the proximal edge of the distal stent. So ostial flaring was done using the same balloon with a modified Zazo wire technique, followed by pot in the left main using 4.5 into 6 mm AccuForce balloon. So again, we crossed the BNW wire in the LCX, and pre-dilatation at the ostial was done using 2.5 into 12 mm AccuForce balloon. After pre-dilatation, we did first kissing in the LCX and LED, and later, since the ostial or ramus intermedius is 90% stenosis, we did POBA to ramus intermedius using 2.5 into 15 mm balloon. So ostial, after doing POBA to ramus intermedius, we did post-dilatation in the LED using 3 into 10 mm Apollo balloon, and same balloon was placed from left main to LED area, and using 3 into 26 mm Resolute DS, the stent was kept in the ostial LCX with one stud protruding into the left main. So using the TAP technique, the LCX was stented, followed by final kissing balloon inflation. So the final IVS run shows good expansion of the stent with cracks in the calcified area. So this is the final result of our procedure, and which shows good results in the LED and L6. So the MS intermediate is stenosis is still there, but since there is a TIMI3 flow, we have not intervened further in the ramus intermediates. Since this patient was critically ill and we don't have any other option, so we opted to go for complex PCI in this case, and patient survived, and he's later on follow-up, the patient LV function improved and he was doing well. So in conclusion, what I like to say is that COVID-19 infection, it makes a stable plaque into unstable plaque, and severely calcified lesions associated with significant thrombus can be safely handled by lithotripsy, and preparation of vessel bed is essential for better results. And CHIP could be the answer to the CABG in critical cases where the surgery is not feasible. Thank you.
Thank you. So that's an excellent cases. Thank you very much, Dr. Harshimran Singh. This is now open for questions and comments from the panels. If no question, I have some query. It is for hemodynamic support. Which one is the best for the IABP or Impella? And so next one is for the lesion preparation. For this case, is heavily calcified.
Yes, sir.
Why you not use the rotablator?
Yes,
and
sir.
For the next question is the for ramus intermediates, you may do the POVA with the DPC, that is drug-eluting balloon.
Yes, sir.
Why not?
Sir, retrospectively, we thought about this thing. We could have used the DEB. And regarding the option for hemodynamic sport, since Impella, it's very costly here in India. So there are affordability issues here, sir. So that's why we opted for IABP sports, sir.
And for the lesion preparation, which one is the best? That is rotablator or high pressure balloon?
Rotablator, The rotabrator is a good option, but if we tried with the IVL, the balloon crossed. If balloon have not crossed, we have kept the option for rotablation. That's why we keep the TPI also ready for this patient, sir.
Okay. Thank you.
Thank you, sir. And secondly, for deep calcium, rotablation can help in the superficial calcium layer. But for the deep, if the calcium is deep seated, then IVL balloon it shows a more better result, sir.
And which imaging technique is best for these cases? For seeing the anatomical aspects of the lesion.
So we have used IVS in this patient. And for deep calcium, OCT could be the option, sir.
Okay, thank you.
Yes.
I request the other panelist for any comments regarding this case. So I think if no other comments or question, that is the time to the sum up the session. And this is the excellent case presentation session and the great session. And I thanks to speaker, Dr. Khairul Shofiq Ibrahim. He demonstrated nicely how to use the IVL in in-stent stenosis in the left main disease. Though IVL is mainly used for the severely calcified native coronary arteries, it may be used in case of in-stent stenosis if the mechanism is consistent with the calcification. And next presenter, Dr. Oelin Chen, and he present a case that is this is TAVR with left ventricular outflow tract obstruction. It is later on find out, but if previously do the best echocardiography, maybe find out in previously, and he managed this case with the dual chamber pacemaker. But now the present guideline shows that is septal reduction therapy by the alcoholic septal ablation is the best option for these cases. But he managed the case very well by the dual chamber pacemaker, and his gradient is reduced significantly. And next case is by Dr. Tomoki OCI Shoren. He present the cases that is TAVR in quadricuspid aortic valve stenosis, but it is very rare congenital disease. Mainly this case is presented with the aortic regurgitation and associated with other several types of congenital anomalies. But unfortunately, he is very lucky that this case is only present with aortic stenosis, no other congenital anomalies, so he may go for the TAVR. And next case is from the Hong Kong, China, by the Jonathan Gabriel Shang. He present nicely how to manage a shock patient, cardiogenic shock with the myocardial infarction. And Thyrawet Gio Pakanan from the Thailand, he nicely demonstrated how retrieve a guide wire from the left coronary artery LAD during a rotablation. And finally, Dr. Harshimran Singh from the India, he nicely demonstrated a case how to deal a patient with a complicated by the COVID as well as severely calcified type-ergated lesion involving the type-ergated lesion. Thank you all, and thank you organizing committee of TCTAP 2022, and thanks speaker for their answering the question, and the thanks the co-moderator and the panelist for the comment and the question, and thanks all for the great session.
Thank you. Bye-bye.
Thank you. Bye-bye.